Good afternoon. Welcome to the last part of this day. Welcome to this conference. It is a pleasure for me to be at a congress as important as this one, where respect for the human life is the priority, and where we emphasize family-centered care with the same relevance as the newest of the technologies. And it's great for me to introduce in this special lecture to Rupali Soni. Welcome, Rupali.
Thank you.
Dr. Rupali Soni is a British-trained consultant neonatologist who has worked at large multi-specialty neonatal units in the UK for 12 years and then in the Middle East for the last 4 years. Her main areas of expertise are family-centered and developmental care, neonatal echocardiography, postgraduate medical education, and neurodevelopmental follow-up for infants and children up to 2 years of age. She has been instrumental in implementing family-centric care at several neonatal units in the UK and the Middle East, and achieved UNICEF baby-friendly accreditation for the NICU in her first consultant post. She has published a number of articles on family-centered care and has led and participated in a variety of research in neonatology, such as Neuroscience Meets Nurture, Challenge of Prematurity, and the critical role of family-centered and developmental care as a key part of the neuroprotection care bundle. Thank you, Rupali, and I'm very happy to be able to give you the floor and listen to you when you want.
Thank you very much for the introduction. Good evening, everyone. I'm absolutely delighted to be here today and talking at the KMC Congress, and thank you very much for inviting me. It has been a pleasure over the last few days to listen to so many of the experts on KMC, and I feel like I've learned so much. My topic for this evening has a slightly different angle. I'll be talking about challenges of prematurity mainly, and the role of family-centered and developmental care as a key part of the neuroprotection care bundle. I don't claim to be an expert on this, but it's a subject which is very close to my heart. And therefore, I have published a review article last year on this, along with my colleagues, Professor Charlotte and Professor Nicola Robertson. I have no financial relationships or conflicts of interest to disclose, apart from being a strong proponent of KMC and family-centered care and breastfeeding. I'm showing you some beautiful pictures of some iconic places in Dubai, where I've come from, which is the Burj Khalifa and Palm Jumeirah. Okay, so my talk's going to cover preterm birth and survival, neurodevelopmental outcomes of preterm infants, preterm brain and its development, MRI abnormalities associated with prematurity, and strategies to improve outcomes, focusing on the role of family-centered care, also called family participatory care, or IFCDC, and family integrated care, depending on which country you come from, developmental care, KMC, and breastfeeding. So nearly 15 million babies are born preterm every year, and that's all babies born less than 37 weeks, according to the WHO definition. And the 10 countries with the highest rates of prematurity account for nearly 60% of all preterm births worldwide. And these are mainly sub-Saharan African countries and Southeast Asia. Majority of these are in the low-income countries, and then lower middle-income countries, and less so in the upper middle-income and high-income countries. However, relatively high preterm birth rates are also seen in many individual high-income countries, resulting in high mortality and morbidity rates. Over the last 2 decades, we have seen an incremental improvement in survival over the lowest gestations, and this is particularly so for the 22, 23, 24 weekers. As I said, majority of the, if you look at this, this map, the darker areas are the areas where there's higher rates of prematurity, and the lighter areas have lower prematurity. And so you can see that it's the African countries and some of the Southeast Asian countries that have higher rates. So if active care was offered, then we would see that even at 22 weeks, currently we are seeing a survival rate of almost 30%, which about 2 decades ago would have been near about 0%. And our survival rates actually have increased over all gestation periods, but more so over the 22-23 weeks because active care is being offered more and more at these lower gestations. But what happens to severe neurodevelopmental impairment? You can see it's kind of the opposite, isn't it? So at 22 weeks, you see very high rates of severe impairment as compared to 26 weeks, where at 22 weeks, you have 1 in 3 survivors with severe impairment, and at 26 weeks, 1 in 10 survivors have severe impairment. So it's quite a big difference, and that's the expense we pay for supporting all these extreme preterm deliveries at 22-23 weeks. So talking about neurodevelopmental outcomes of preterm infants. Severe neurological disability, cerebral palsy, and intellectual disability is much less now as compared to what it was a couple of decades ago, but we still see 5 to 15% of very preterm survivors still being affected. We see milder cognitive disabilities, learning difficulties, and behavioral problems in 25 to 50% of children at preschool and school age in this preterm population. Motor, cognitive, behavioral, and psychiatric disabilities in the moderate and late preterms, however, have a greater impact because our extreme preterm babies are much less as compared to the moderate and late preterm infants, which is a much larger population. About 0.9 million of these babies suffer long-term neurodevelopmental impairment, and 345,000 moderately or severely affected. And that's quite a large global burden to be dealt with. Outcomes at school age and beyond, when we look at neurodevelopmental outcomes, are much more valid compared with early assessments. So if you make an early assessment, you might not get a very accurate assessment in neurodevelopmental outcomes as compared to school age and beyond. And we see that male gender and lower maternal education have shown to be associated with lower early learning composite scores and a decline in scores over time. And BPD is found to be a crucial factor for cognitive outcomes, and it does impact cognitive outcomes significantly. So when we talk about motor impairment, we're talking about cerebral palsy, developmental coordination disorders, and other disorders of movement and its control. And prematurity is the most frequent cause of cerebral palsy, with an incidence of 9.1% in adults born at 23 to 27 weeks gestation. And majority of this is the spastic type, of which spastic diplegia is the one that we see more commonly. Cognitive scores at school age and beyond may be 11 to 12 points lower in children born preterm than those born at term. And their mean IQ can be 5 to 7 points lower than in controls. They would experience difficulty in tasks such as initiating activities, organization, flexibility in generating ideas and problem solving at school, working memory, inhibition and attention problems, and visual motor integration. They also have problems with behavior, speech and language, and academic achievements. When it comes to behavior, about 40% of preterm infants have an overall atypical pattern of behavior with respect to processing sensory stimuli. 90% have an abnormality in one or more sensory processing domains, such as oral, auditory, tactile, or visual. And extremely preterm infants are 4 times at risk of having ADHD and ASD compared with term infants, with 25% having psychiatric disorders. In terms of speech and language, speech development is more delayed than motor or cognitive abilities in early childhood. And expressive receptive language processing, articulation difficulties, and deficits in phonological memory are seen at an older age. They're more likely to have 2.85 times more likely than their term peers to receive special education at school, and score significantly worse in arithmetic, reading, and spelling. And their socioeconomic status is an important modifier for this. So let's look at preterm brain development and reasons for really why these impairments happen, why these motor, cognitive, behavioral, psychiatric problems happen in preterm babies. So the growth rate in the human brain is higher than any other organ from the 4th post-conceptional week to the 3rd postnatal year. Most developmental processes extend into the postnatal period, especially those associated with interneuron connectivity. And they're very much vulnerable to environmental influences that their impairment may disrupt brain growth. The 3rd trimester is really a very critical period where global and regional volumes increase 3 to 4-fold. And so what happens to our preterm babies? They're actually spending this 3rd trimester in the NICU environment. That's not where they're meant to be, right? So this is a very critical period, and that's the period where they are being dealt with in the NICU. And prematurity is one of many biological or environmental insults which can push the trajectory of the developing brain to an atypical path. So them being on the NICU rather than being inside the mother's protective environment of the uterus can really push them to an atypical path of brain development. And this results in increased neurodevelopmental and neuropsychiatric disorders. So this is an image from our article, and you can see that many of the important processes like synaptogenesis, the blue one on top, axonal growth, migration, myelination, and dendritic differentiation, a lot of them are peaking in the 3rd trimester. So the red dotted line is when we would start resuscitating our preterm babies, so around 22, 23 weeks. So majority of our preterm babies are born after that red line. And as you can see, majority of the brain processes are happening just after that period. And the highest risk of white matter injury, so the white matter injury in preterm babies, coincides with the period of the pre-oligodendrocyte period. You can see in the gray zone. And this is when we see between sort of 22, 23 weeks to about 32 weeks, the highest risk of white matter injury in our preterm babies' brains. As they mature, their risk of intraventricular hemorrhage or germinal matrix hemorrhage decreases with gestation up to about 32 weeks, but the abnormal cerebral maturation continues until term age. At the bottom of this image, you can see the functional milestones. So a lot of other functional milestones are being achieved during this period as well, such as response to light, nociception, neocortical evoked potentials, response to touch, and all of these are developing during this 3rd trimester, which potentially for many of these preterm babies could be spent in the NICU, being exposed to a lot of noxious stimuli, such as painful procedures, not being with their mother, being, exposed to intense sounds, lights, and all the things that they're not supposed to be exposed to. So the sensory development of the fetus, undergoes a sort of a pathway as shown in my slide, and the neural architecture of every sensory system is built at 22 to 24 weeks and further develops in the neonatal period. The hearing system is nearly fully developed at 20 weeks, and an unborn baby can respond to loud noises by 23 weeks. The baby's eyes are susceptible to bright light, but they are short-sighted when they're born. They can see up to 8 to 12 inches in front of their face. And all these NICU environment and stressful events and procedures can potentially alter the brain development and their subsequent behavior. So this is what is really, really important, and what is the crux of what happens on neonatal units. The brain growth in preterm infants, the growth trajectory during 25 to 40 weeks on NICU is less than in a healthy term fetus over the same duration. So when you compare term babies, a baby who was developing inside the mother's uterus to a baby who was developing outside the uterus on an NICU, we see that the growth trajectory is very different and is less than the baby that was developing inside the uterus. There is reduced cortical and subcortical gray matter volumes, and long-term effects of prematurity are observed by the alterations in white matter and gray matter volumes seen even in adolescents. Preterm infants at term-corrected age have impaired cortical development with decreased cortical folding, and reduced gray matter volumes are associated with fetal growth restriction and slower postnatal growth. So, as you can see, A and B are preterm brains. So A would be something like a 22, 23 weeker, B would be something like a 28 weeker, and by 37 weeks, you have all the folds, or gyri and sulci, that should be there in an adult brain. And so if this brain from A, B, and C is not inside the uterine environment, the development of this brain is quite different, and it occurs in a different trajectory as compared to what is in the uterus. Studies have shown, like the study by Capillo, have shown that abnormal cortical development after preterm birth occurs, wherein your cortical folding actually happens at a higher rate in normal babies as compared to the volume. So your cortex increases in size or surface area much quicker as compared to the brain volumes. But in preterm babies, this increase in surface area happens at a much slower rate than in babies that are developing inside the uterus. And that potentially impacts on their neurodevelopmental outcomes and impacts on what we see, as I've already described, motor, cognitive, behavioral problems that we see in preterm babies. So now that with the development of neonatal care, we don't get to see a lot of babies with severe intraventricular hemorrhages or periventricular leukomalacia, but we're seeing more diffuse and subtle pattern of white matter injury and punctate white matter lesions and destructive and dysmaturational effects, abnormal white matter and gray matter development, rather than the big IVH or porencephalic cysts that we used to see before. But we still cannot reliably predict outcomes based on MRIs other than lesions, other than PVL and hemorrhagic periventricular infarction. Now, if you look at, the upper images are images of a term baby who was born at term, and so if you look at the three images, A, B, and C on top, you will see that there is quite a lot of cortical folding. The space between the folding and the skull is not so much. And the space, the interhemispheric space is what we call it, space between the two hemispheres is small, okay? And the ventricle size is also thin. The ventricles, those areas in A and B, you can see are very thin. The lower images, D, E, and F, are those of a preterm baby who has had an MRI scan at term age. Okay, so they're both term babies, but the top one developed inside the mom's uterus, and the bottom one developed on the NICU. So can you see a big difference? You see how D, E, and F, you see the brain is scaphocephalic, or the head is scaphocephalic, or it's narrow and long, as compared to A and B. Plus, there's more space outside the brain, so there's more free space, and the cortical folding is much more immature as compared to the top images. Yeah? So there's less folding, and it's not so deep. And also the space between the hemispheres is much more. The ventricles are bigger, and so it just shows that there's less volume in this brain, and the cortex, the cortical development, then the folds are much less. And this is typical of preterm brain at term equivalent. We also see what we call punctate white matter lesions, and these are quite typical of preterm babies, and if they are seen like the ones in these two images, then they are associated with abnormal motor outcomes at 20 months of age. Okay, so we've talked about the problem, why there is a problem, and why there is such a big burden of prematurity, but what do we do about it? There's lots of medical therapies that can be used and which are being used, such as having good obstetric care. Antenatal steroids and magnesium sulfate are heavily recommended. Caffeine is shown to improve survival without neuromotor disability. Delayed cord clamping, although it improves cerebral circulation and transitions babies cardiovascularly, it has meta-analysis haven't really shown a significant benefit yet for improved neurological outcomes. Erythropoietin, again, although it showed positive results in preclinical trials, hasn't actually shown in the trials thus far, hasn't shown a positive effect in terms of improving neurodevelopmental outcomes. Mesenchymal stem cells are a promising therapy, and they have been shown to, in animal models, to decrease inflammation of brain cells and decrease apoptosis or cell death. And these can be given intranasally and are present in abundance in breast milk, actually. So it is a promising therapy, but again, it's still being investigated. So what about our non-medical therapies? Yeah. Historically, a lot of simple measures, such as things like hand washing, have been largely neglected and ignored, and so also for non-medical therapies, because it doesn't involve expensive medications, large expensive trials, and so sometimes these therapies are not so well understood or not so well implemented, but the lack of awareness is an issue, and recognizing the importance of these therapies is so important. So admission to an NICU is quite a traumatic experience for not only the baby but also the family. And poor psychosocial functioning in mothers and fathers and negative parenting behaviors has been seen. The technical environment and the NICU architecture may pose barriers to physical closeness, and animal studies have shown quite well that prolonged physical separation between the parent and newborn alters brain development and results in higher cortisol levels in infants and is associated with stress and anxiety in parents. So family-centered and developmental care practices, which you all know very well about, so I'm not going to go into details about what they are and what they entail, and NIDCAP, of course, a very important strategy for improving neurodevelopmental outcomes. Family integrated care is a more recent sort of progression of family-centered care, where parents are made an integral part of the care of the baby and spend several hours with the baby and take on more responsibilities for the baby and work together with the NICU team to look after their baby. And these are the 4 pillars of family integrated care. So benefits of family-centered and developmental care are several. They enhancing neurological, neurobehavioral, neurocognitive outcomes, increasing parent confidence and competence, increasing breastfeeding rates, infant growth, skin-to-skin promotion, pain management, infant touch and massage, improved sleep patterns, positive auditory experience, decreasing infants' cortisol levels, accelerated brain maturation, particularly in the frontal brain regions, cerebral cortical development, interactive communication with the parent, reduce short-term and long-term parental stress, and all of these benefits essentially from having closer contact with parents and the developmental care strategies that are being used. So when we look at KMC and skin-to-skin, now this is what the baby would experience inside the mother's uterus. They basically feel safe and protected, and they have reassuring experiences, like the movement from the mum, they hear mum's voice, they hear mum's heartbeat, they sense mum's emotions, they can feel the mummy's hand stroking the belly, and they can smell or taste the amniotic fluid. They have natural boundaries, and they have a constant temperature, and they don't feel pain, and they feel held and contained and safe and peaceful inside the mum's uterus. So what happens when they're suddenly born preterm? It completely changes. Yeah? So it's nothing like the uterine environment. They feel bumps and movements of the incubator, bright lights for sensitive eyes. They cannot hear their mum's voice. They can't hear her heartbeat. They hear the beeping monitors in the NICU and strange hands and voices that they've never heard before. They smell the antiseptic and plastic from gloved hands, and they are fed through IV drips. Temperature changes as the incubator door opens and closes, and the pain of needle pricks. Do not feel contained, hear loud sounds and strangers' voices and slamming of incubator doors. And surely that experience during that developmental phase that I showed you on that initial diagram is just so disturbing, isn't it? Because they're going through all of these painful and uncomfortable experiences during that crucial phase of their brain development. So how can we help that? Skin-to-skin and KMC, they can still feel can hear their mum's voice, they can hear mum's heartbeat, they can sense her emotions, they can feel their mum's hand, they register day and night, they can smell and taste mum's milk, they have a constant temperature, they're calmed and comforted during painful procedures, and they are feeling safe and peaceful and can sleep peacefully and brain wire properly. And so this is the closest that they will get to the uterine environment. So it makes a big difference to what they're experiencing outside of the mother's uterus. So several benefits, and this is not a complete list. There will be many more. Decreased cortical reactivity, improved brain blood flow, so all the positive experiences, all the positive effects on the brain, reduced stress, neonatal stress scores, increased oxytocin levels, supporting infant physiological stability, and improved executive functioning even at 5 to 10 years of life, and reduced HPA axis response to pain, so the hypothalamic pituitary adrenal axis response to pain is very much reduced by KMC and skin-to-skin, and it's an important factor that influences brain development. Reduced length of stay, impact on self-regulation, promoting neurobehavioral development, and long-lasting social and behavioral effects even after 20 years of KMC, which have been reported in various publications. Benefits of breastfeeding, again, this is it's a huge list. I've only listed a few. So cognitive and developmental advantages, intellectual development through to adulthood, improves cardiovascular health, increase in total white matter and gray matter and parietal lobe cortical thickness, improvement in cortical and cognitive development, mature early myelination of early neural pathways, social, emotional, and health benefits, and dose-dependent improvement in microstructural properties of white matter tracts and cerebral structural connectivity. Immune and inflammatory modulation and metabolic advantages are only some of the advantages of breastfeeding. In preterm babies, the three most problematic problems of preterm babies, like chronic lung disease, shown in that X-ray, retinopathy of prematurity, and NEC, or necrotizing enterocolitis, have all been shown to be reduced by use of breast milk. So it's, when I go to mums to ask them to express milk, I tell them that it's a medicine. It's your baby's medicine. So if it can reduce all these medical problems in preterm babies, of course it's a medicine. So very, very important in preterm babies. And we've also seen in publications that there are long-term cardiovascular effects of breast milk in preterm babies, which are due to the VEGF, adiponectin, immunoglobulins, lactoferrin, stem cells, and HMOs produced in breast milk, which you cannot otherwise produce and give to the baby, and very, very crucial for cardiovascular health in preterm babies, in term babies as well, but more so in premature babies. So, yes, of course, you know, I'm not against formula milk because there is a subgroup of babies who will need formula for medical reasons or where milk is just not available, donor breast milk is just not available. And they've done very well, actually, to be honest, with adding so many important vitamins and constituents in formula milk. But I think being a woman, I can safely say that they will never be able to beat us when it comes to breast milk. And this slide still gives me goosebumps when I look at it. It's amazing what breast milk constitutes. So, in conclusion, the third trimester is a critical period of brain development, and for our preterm babies, this is spent on the NICU. And remember, when you're dealing with a preterm baby, you're literally carrying their brains in your hands. So, you know, you cannot be more careful with these babies. And that's the biggest difference in having a preterm baby on an NICU as compared to an adult on ICU or a child in a pediatric ICU, because their brains have already developed. In this preterm baby, there is so much going on in their brain that everything that you do to this baby impacts their brain. Family-centered care or family participatory care or IFCDC and developmental care promote parent-infant interaction, which is very, very important for these preterm baby brains. And there's a host of benefits from skin-to-skin, KMC, and breastfeeding. It is safe and feasible in most settings and socioeconomic conditions, and enhances the baby's preterm experience and improves neurodevelopmental outcomes globally. And, you know, I've already described how big a global burden prematurity is. And if we can have a simple intervention as easy as skin-to-skin and breastfeeding, which is cost-effective, it's not fancy, it's not an expensive medication, why not do it? And it should really be part of neuroprotection care bundle and is an important consideration in future clinical trials. Thank you very much. Do you want me to sit down? Yeah, I can sit down.
Thank you, Rupali. It's the time of the audience. Is there any question to Rupali?
Thank you for a great talk. I'm Anne Eerlijkes. I'm a neonatologist from Belgium. I would make a comment and have a question about the MRI images that you showed, because it's something we often do in preterm infants. We make MRI images and we see abnormalities, but we are not sure what future will bring. And I found it very difficult to talk with parents about it, because I don't want to undermine their confidentiality in their child. I want to give them a hopeful message. We have all the brain plasticity that is still going on. But on the other hand, we have those results we look to. It's difficult. For me, it's a dilemma. Can you comment on that?
Yes. Thank you. That's a great question, actually. We're able to do MRI scans on newborn babies now at term, and that comes with its cost, as you describe. So often you will find certain things on MRIs which you unexpectedly find, and what does it mean? So and that happens often, right? You see a little spot there. What are you going to tell the parents? It's a difficult situation because you've done an investigation, you found something, and you don't want them to go away thinking for the rest of their life that something awful is going to happen to their baby. And this is the difficulty we find with MRI scans, and we acknowledge that predicting outcomes based on MRI scans is still very elusive. It's not a definite science. When we look at predictors of cerebral palsy, for example, we look at Prechtel assessments and Hammersmith assessments and MRI together. And so we wouldn't tell them that a spot on their MRI scan means that something awful is going to happen. So apart from periventricular leukomalacia or IVH, apart from those injuries, there's very little predicting that you can do from an MRI scan, really, and it's a difficult situation when you see something there. I usually don't worry them. I usually say that what we see in clinics and what we see in terms of what they are able to do later on in their neurodevelopmental assessment is much more important than what the MRI is showing, unless it's a large intraventricular hemorrhage or periventricular leukomalacia, large lesions like that, which are a bit more predictive.
Any question? Perfect time.
Okay, thank you.
It was a very nice presentation, hypnotizing, I would say. I mean, all the slides had very important messages. I have just one curiosity, that as you described the preterm brain development in utero, and then when they are in the NICU, and then when they are in KMC, can we do something more with the KMC to enhance the development of the premature babies? Like it was mentioned that they need darkness to develop eyes, or so can we put some extra precautions or extra measures to enhance?
I think there's a lot of things, thank you for your question, there's a lot of things that we already do as part of, say, NIDCAP and developmental care, so, regulating their light and dark periods, trying to limit noise, so all of those things, along with KMC, are very important. So, my answer to your question would be developmental care interventions.
And darkness, I was just wondering, and another question is that the touch is the first sense to develop in the fetus.
Sorry?
Touch, tactile sensation is the first to develop in the fetus.
Correct.
So they experience more pain. But is it so that they are soothed also, like they can be soothed also very by increasing touch interventions?
Yes. Absolutely.
That pain can be the negative experience can be converted into positive experience.
Absolutely. So when babies were, many years ago, when babies were admitted to NICUs, it was felt that parents are not to come in contact with babies. They should be put in incubators, and so these poor babies got all the negative experiences of the NICU and no positive experience, and that's very sad, because it's such a simple thing. Bring the parents in. You know, they should be part of the furniture of the NICU, and so now we've learned to do that a lot more. They're there, they are part of the care of the baby, and they're providing the positive experiences that these babies need for their brain development, and that's so important to emphasize all the time, that parents are the positive experience. Breast milk is the positive experience. KMC is the positive experience.
Yeah. Would kinesthetic or tactile experiences would help?
Yes, definitely. So touch, positive touch and massage have already been shown in studies to help with improved neural connectivity. So that definitely does.
Thank you so much.
Thank you.
Hello. I came from the parent side. So I really think that the parents should know about what you found out on MRA. Is it any, my question is there is any tool to measure their pain sensitivity after the NICU period? Is it something, because my daughters are saying that the pain is on a higher level than I feel. Yes. When they fall down or in such normal situations.
There are established pain scores that have been used in newborn babies and preterm babies, if that's what you're alluding to in your question.
Not on the NICU stay, but afterwards, to measure if they have a higher level of pain sensitivity.
Yes, I mean, there are, as I say, pain scores that can be used in certain age groups, and they can be used to check their pain sensitivity. But are you asking if preterm babies have a higher pain sensitivity?
Also this.
Yeah. Well, they have been shown to have abnormal sensory motor issues, so yes, that can heighten their pain response. And their experiences on NICU will influence their pain response, and we do see that in a lot of our preterm babies.
And the second question is if you use the general movement assessment to see the risk of developing disabilities future in the life.
Yes, we do. Practal and GMA is a very important tool, and along with your Hammersmith assessment and your MRI together, it's very a good predictor of cerebral palsy in babies less than 5 months.
All three of them together?
Yes, together.
Okay, thank you.
Okay.
Clarification. Is now KMC considered as a part of NIDCAP, or still it is considered different?
So I think some of the NIDCAP experts might want to answer that question.
Because
I would say
a few discussions about that KMC is now being merged with NIDCAP. So I don't know, I wanted to clarify. And another thing is, there is another V developmental score or something in that. WEE, some 7 lotuses and that thing. There also KMC is an integral part of that developmental score.
So there are a number of developmental scores in use.
This is a developmentally supportive care, rather.
So in various countries, there's a number of developmental scores, and that is one of the scores. However, going back to your previous question about KMC being part of NIDCAP, I know that there's many more experienced people here who might want to answer this question.
Well, I think Björk can be better than me.
Maria is a NIDCAP trainer.
Yeah. I see a lot of heads
shaking. I'm a NIDCAP senior.
Yeah.
I was certified 1991, I think. So, but NIDCAP, I don't know how we should summarize it, but it's certainly a method where you train the staff and the parents to learn the sensitivity of the infant and also to interpret the behavioral communication of the infant, and thus you are trained how to adjust the environment according to the needs of the infant. And we could say that I loved your slides about KMC, because KMC is a very strong instrument for achieving this. But when you are doing the KMC or skin-to-skin contact with the extreme ones, the very small ones, then of course it's preferable that you are trained how small adjustments of positioning could actually enhance the circulation, also enhance the saturation, and so forth. And as you alluded to, a combination of all these things, actually, it's not one thing, it's a bundle of things, and skin to skin is a very essential bundle. And Maria?
Yeah, I will, because in the workshop, Niels told us that it's all about co-regulation. And KMC is a tool for co-regulation, and it can maybe give us the word of the baby that telling us how it's going, everything.
Earlier I am aware that they were considered separate, but recently there was an article that the KMC is considered as a part of NITCAP. So I just wanted a clarification.
We are really discussing.
Let me say something, okay? I mean, NITCAP at the beginning of the NITCAP. I meet Dr. Arls. No, when she began to describe it, kangaroo was not in the NITCAP. And the kangaroo position, and we did a special edition in the current Women's Health, and we had a discussion on that, but it's without any interest. For me, NITCAP integrates the kangaroo position, and it's perfect. I mean, there is absolutely no problem. The kangaroo mother care method is a method, a full method with the kangaroo position, with the kangaroo nutrition since 78, and with the early discharge in kangaroo position at home, where the parents learn how to manage their infant, and we have this result on the brain with all this rule intervention. We meet in a workshop in Gmund, and we were invited, you for the NITCAP, I was invited for the kangaroo mother care, and it was very interesting. But I think we are working for the same thing. I mean, there is no interest to say, I put here this, I put here that. The kangaroo mother care is not only the kangaroo position, as you say, it's another thing. It's a
Infant and family-centered developmental care. That is the generic terminology. And you can have many interventions. Like the family-integrated care is also very good to support the development of the dyad, the mother and infant dyad, because they would give you a structure in the hospital. They would give you a system of families being present during rounds. They will give you a system where you actually educate families. You put resources in parents' education. But when we, of course, I believe in skin to skin. Why do you think I engaged? Actually, it was Niels and I that initiated the immediate skin to skin study. Because we think it's so essential, especially if you have a context where you cannot train people in observing infants. So what you have done in India is fantastic, and that's an enormous action for promoting infant and family-centered developmental care. In India, you call it family participatory care, and it's a variance. We want the family to participate, but we also, a premature infant, I mean, if you study very small infants, and they are very unstable, and you've talked about the very low gestational age infants, they are different. You could see the brains, of course they are different. And if you study thousands of infants with just skin to skin, I totally agree. Your findings are probably very true and very correct. But for the individual family with a very, very small infants, you are definitely helped to have someone with Maria's competence to guide you how to interpret the signs, and then you can make small adjustments. And I can promise you, it's extremely seldom. I never prohibited skin-to-skin contact. We do it with mechanical ventilated infants. We do it with infants that need pressure agents, very sick infants. We do skin-to-skin because it helps. So there's no contradiction. I have a slide which I made, just a second. Yeah, wait a minute, but I would just like to explain one thing. If you have, thank you. Together with a nurse, professor in nursing in Sydney in Australia, we decided that the NITCAP Federation International didn't have, we needed more global perspective, because this was developed in the US and we also have used it in Europe. And it's too narrow. You need the perspective of Natalie. But if you look at different programs, at the top, which doesn't take so much training, is breastfeeding. You need to do breastfeeding for everyone. And so the other triangle is very wide. So everyone should have breastfeeding. Then come skin-to-skin contact for stable infants. You don't need that much training, actually. In Cameroon, they had 12 days of training for the KMC trainers in that country, and I think that's probably good enough. And then you have KMC for the unstable babies. That needs more training. We talked about securing airways, for example. And then you have a more complex training like FICARE. It takes a little bit more to do that. And you will never be able to give that to the global, to all these 20 million low birth weight infants per year. So there's no contradiction, and we should definitely continue to support skin to skin as much as possible. And I totally agree with the follow-up program is also extremely important.
So look, pyramid of prematurity is like this. So 22, 23, and especially in which country, I mean, you will do that. But I'm trying to think to all the premature infants up to 37, 2.5, which has a numerous baby. And yes, our result on the brain are with this infant from 32 up to 37. So it's very important, the concept. When you say to train, to do kangaroo, it's nothing. No. I can tell you that you have to train people to do kangaroo well, and the mother is the one we train. So people are trained, and they are going to train the mother. All the kangaroo program is how to make family to be the best provider. It's not a specialist who is going to do that. We are doing everything for the mother because she's the best when she's trained, because she's the mother. But 30% of our sample go at home with less than 72 hours because they have immediate kangaroo and they go home and they come back because they are effectively stable since birth. So just wait a minute. What I want to say, the kangaroo position is not NITCAP is perfect, and for the more immature infant, it's perfect. But kangaroo mother care is not only that. Kangaroo mother care, it's a kangaroo method for all the premature and low birth weight infants. You have to learn how to do it. When you speak about breastfeeding a premature infant of 30 weeks is not 22, is 30 weeks, and it's very difficult. And if you want the baby from a unit to go out with exclusive breastfeeding, it's a terrible work. And from intensive care unit in any of low and middle income country, it's very difficult not to be able to do that. And that's a challenge. The challenge is not is for all these babies hospitalized. And the early discharge in kangaroo position when the mother is trained with the follow-up, it's what you allow, you teach the mother, and she's allowed to read her baby, to understand the baby. I remember that Gmund, I think it was more than 20 years ago, I told you as a joke that we were training the mother for free, because the knit cap is very expensive, and we were training the mother for free. Because it's true, you teach the mother how to understand her baby, and you can say one thing, the impact on the brain, I don't know if you agree with me, the impact on the brain, it's an impact, probably, or theory, it's an impact anatomical and physiological for the brain to be here, and the impact on the family will do that they will stimulate outside.
Excuse me. There is another question.
Kangaroo care is not kangaroo position. It's too, how do you say, it's a component.
Let's gonna open the discussion for Dr. Anna. Maybe we can be in the middle.
I just wanted to answer the question that the parent had asked. Is, I agree with you, Natalie. Kangaroo mother care is the bicycle, which everyone can afford. Knit cap is the Mercedes, which only few units can afford. So I think it has those are different, in my mind at least, different, rules. But for babies who have been through the NICU and they're growing up and all that, if you want to get pain threshold testing done, there's something called QST. It's quantitative sensory testing, and it can test, mechanical, thermal, other kinds of thresholds. And then there's also a handheld dynamometer, which tests simply pressure pain thresholds. It's not noxious. It doesn't, the baby, the child will not, start crying with it. But it's just gets this. So, there's a lot of data that is published on ex-preterm babies or babies who've had surgery in the neonatal period, where they seem to have higher sensitivity in the area of the surgical incision, but lower sensitivity to pain in the rest of their body. So there are things that are published using QST.
Are you okay? Well, I think NICAP is for all the babies, not for the preemie. If the problem is the cost, I totally agree with you, but we have to fight for both. If you know that something is good for the babies, you have to fight for both and work together, no?
But for the 20 million infants, babies, newborns, of course they cannot have NITCAP, but you are a professor, we have a professor, of course education is good for if you have experts and you can use them as consultants, but for the 20 million babies born every year, of course breastfeeding and skin to skin must be the basic, definitely.
Yes, and the empowerment of the mother and the education of the mother. That's very important.
I think, I just wanted to say I would agree that breastfeeding and skin-to-skin KMC are so much more accessible. And NIDCAP, although an excellent intervention, in all the NICUs that I've worked, it's an expensive training. It's a long training period. And so, you cannot always get enough staff who are experienced in NIDCAP, and that's the difficulty we've faced in some of the NICUs that I worked in, whereas KMC and breastfeeding are just so accessible, easy to implement anywhere.
I want to say that for the very immature infant, association of NIDCAP and the position showed results. I mean, it's not so frequent. You are speaking about 22, 23. Yes, I mean that it's true. I say it's true. It's only a part of kangaroo, but it's very important. The position is very important.
I just remember that in the European standard that the Parents Association done for us, they recommend education and define that it means the first step for NIDCAP maybe can be one of the part of the solution of the problem. We start with not very high education. We go a little bit down, cheaper, feasible for the NICUs, and after that maybe you have a lot of fine people, you can go to fine two, but the people have knowledge about the behavior, and for me it's the key point.
The difficulty we have, look. The difficulty we have as doctor, neonatologist, pediatrician, expert, is to transfer the responsibility to take care of this baby to the family. Sure. Yeah, that's a big problem. The NIDCAP still is something medicalized. Just 1 minute. I mean, it's very medical. It's the expert who is going to do that. And I believe personally that in kangaroo mother care, it's lacking teaching to the mother since the beginning effectively that NIDCAP could do.
Let me tell you that when we are teaching, all the trainees wants to make an observation in kangaroo care with mother and father, because it's the best training that you can have. Looking the neurobehavior of the baby, co-regulating with the parents and the mother. Is the best exam that you can obtain for the mom and for the baby and for all the professional learning for the family. We will try to do this. And then the baby is going to sleep and you just pass your exam because it's in kangaroo.
Okay. Thank you. Thank you, fantastic.